Of palpitation on exertion since 15 years. Palpitations on exertion since 15 years. Dyspnea on exertion from 3 years. Yes.
That's why I asked.
So, history of presenting illness. The patient was apparently normal since 15 years back. He presented with the history of palpitations on exertion 15 years back, which he was consulted, which was insidious in onset, gradually progressive. Initially, for the climbing of 2 flights of stairs and walking on the level ground for 2 kilometers, for which he consulted Sathya Institute of Puttaparthi in 2010, for which he was diagnosed to have a cardiac problem, and he underwent an groin procedure and advised for the surgical correction for the same, but he was not operated due to some personal reasons, and he took medicines for a few months and he stopped the medicines and he lost follow-up. Now, sir. Now, so for which he underwent the groin procedure and he advised for the surgical correction for the same, but he was not operated due to some personal reasons, and he took medicines for a few months and he stopped. He stopped after that, and he lost the follow-up, and he developed the palpitations again, like from past 6 months, which was even for walking for 100 meters from the past 6 months, it was increased.
Sir, palpitation 15 years.
15 years. And after that, he was on medicines for some time, ma'am. And after that, he stopped the medicines and it got worsened from past 6 months. While walking on a level ground for 100 meters and climbing for 1 flight of stairs, which was regular in nature, relieved unrest and not associated with giddiness or syncope. And had a history of dyspnea on exertion since 3 years, which is insidious in onset, gradually progressive. Initially for climbing up 2 flights of stairs and gradually progressive since last 6 months, he developed even for walking for 100 meters and 1 flight of stairs on walking and lifting heavy objects, which was relieved on rest and not associated with any PND, orthopnea, or cough or wheezing. But a history of fever with productive cough, which is white color mucoid, had a history of fever with white color with productive cough, white color mucoid expectoration for a period of 1 month, 6 months back. So which he was treated with IV medications and oral medications from outpatient department, which he was advised for hospitalization, but he didn't admit that time. And there is no history of chest pain, no history of easy fatigability, no history of abdominal distension, palate edema, or puffiness of the face. And there is no history of joint pains or rash in the childhood. And there is no history of monthly IM injections. And no history of warm intolerance, sweating, or sleep disturbances. And there is no history of recurrent respiratory tract infections or sinuses in the childhood. The past history, there is no history of tuberculosis or diabetes, hypertension.
Is there any positive history there? Any important positive? Just concisely summarize.
40-year male patient. He was.
Before that, 1 minute. Palpitations you mentioned. Did you mention any other also in terms of palpitation?
Syncope and no post palpitation picture.
Not there.
Not there. So 40-year male, he's a tobacco chewer with no medical comorbidities, presented with exertional palpitation since 15 years and exertional dyspnea since 3 years, which got from NVHA class 2 to NVHA class 3 from the past 6 months. and he was diagnosed to have a cardiac problem since 2010, which he underwent a groin procedure and suggested for surgery, but he was not operated. And he was currently on a oral diuretic therapy.
Or some fever also,
He had a history of a fever 6 months back for a 1 month,
come back.
6 months back. He was advised for hospitalization, sir, but he didn't get admitted, so he was treated with injections in the outpatient department.
You say he underwent some procedure, you said,
Groin procedure. Yes, groin procedure in 2000.
groin procedure.
Cardiac catheterization problem.
Yeah.
Clarify that. So what is the function class now?
He's in functional class 3, sir.
As per the dyspnea and concern, dyspnea.
Dyspnea, sir.
And what is status of palpitation now?
The palpitations also class 3, sir.
Now, what could the nature of palpitation here? Arrhythmic
Sir,
palpitation?
palpitations are regular, sir, on exertional regular palpitations, sir, which is relieved on rests.
You mean what is it? Because of arrhythmia or because
Sir,
of
it could be because of volume overload, force of contraction.
what's whose ventricle? Ventricle or atrium?
Sir,
Volume or ventricle or atrium?
ventricle,
Which ventricle? Either. Which ventricle volume overload can produce palpitation? Left or right or both?
Both.
Only right ventricle volume overload
right ventricle can also produce
can palpitation. Tell me some conditions where can RB volume overload.
ASD.
Only ASD.
ASD.
Only ASD.
No, sir.
Any other conditions?
Uh,
RB volume overload.
Sir,
People have to
Down.
participate. RV volume overload, any other condition, anyone can take it.
TR.
Huh?
Here TR1. And
Fever TR. Okay, fine. Then primary or secondary or either primary, secondary or both.
abstain, sir.
No, primary TR or secondary TR. Which TR can produce volume overload or both? Both. Then
Cyanotic.
Anything else?
Stop-
Any
stop
other
with,
regurgitation?
Off with
any other condition can produce RE volume overload.
absent pulmonary wall. With
Causes
pulmonary
what?
Pulmonary regurgitation.
Then
Abstain.
abstain volume overload. RB is dilated in absence.
Cape.
The pre-tricuspid shunts.
Restrict-
Pre-tricuspid shunts can produce volume overload, right ventricle. So either tricuspid regurgitation or pulmonary regurgitation can produce volume. Isn't it? So he had palpitation for last 15 years. Now palpitation worsen. And in addition to that, there is
Dyspnea.
dyspnea added. And fever one year ago,
6 months ago. sir.
6 months ago fever. So tell what diagnosis.
After that, the symptoms worsened,
Yes.
the onset of fever. How long he received treatment?
1 week to 2. 1
Pardon?
week to 2 weeks he received. In only outpatient department he received.
Was it suggestive of endocarditis?
There is no diagnosis of that, but
From history, you can think of endocarditis from history.
sir, he has a fever for 1 month. So possibly
Lung fever.
because underlying cardiac, because he has an underlying cardiac issue.
So he has got existing cardiac condition and history of fever there for 1 month. So possibility of endocarditis is there. You can't say you can't I rule out or rule in, but possibility. Diagnosis. Keep 3 diagnoses.
Possible diagnosis of ASD with PH, PSD with PH,
Huh?
Huh?
PSD,
Why
Yes.
ASD?
PSD AR.
PhD. PhD here. B or A?
P,
B.
Also said ASD, right?
AS, ASD,
PhD palpitation and that too.
SDP.
PhD PH.
Is there any orthopnea PND? You didn't
No.
mention.
Palpitation and dyspnea. Why dyspnea develop PhD patient? Palpitation fine, okay, RB volume. What could the cause of dyspnea in any AST?
Because of pulmonary age,
How would pH produce dyspnea?
increased pulmonary blood flow leading to decreased lung compliance, increased resistance to the airways.
With that endocarditis, is a possibility, isn't it? Would you like to add something for that, your diagnosis?
Is endocarditis common in AST? Atrial septal defect? AST.
Why?
Low pressure,
Huh?
low pressure,
No?
Low pressure.
Low pressure, how do I relate to low pressure, high pressure? No, endocarditis. Endocarditis in relation to low pressure, high pressure. If it happens, which valve usually affected endocarditis?
Which valve will be affected if they develop endocarditis in AST?
Supposingly endocarditis there, which valve or which area? Intraseptal area or atraseptal area or valves? Which area will be affected and which valve is affected? Possibility.
said
Tricuspid. Okay, fine.
Tricuspid.
Tricuspid, okay, low pressure also. Unless patient has got, okay, fine. Then tricuspid, then
with pulmonary.
pulmonary. Mitral?
Associated lesions, AST patients?
ASD.
Mitral prolapse occurs.
Maybe.
30% cases in mitral prolapse occurs ASD. Make it mitral endocarditis also. Very uncommon in ASD. Source in abstinence also very uncommon. They are immune to endocarditis.
You said he was advised surgery 10 years back only, no?
15 years back.
For just palpitation, he was advised surgery.
Yes, ma'am. After the procedure, they advised for surgery.
So your diagnosis was BHDR and ASD, HDPH. No, any other diagnosis you want to put? Put a case of abstinence anomaly. Palpitation, breathlessness.
CAT study.
No, they did. Cash study did. They did cash study. Cash study or RFA, RFA, how do you know this? For palpitation, could be admitted. They could have done RFA, EPS with RFA. You don't know what they have done. Only the ground push done.
But he was advised surgery.
That advanced surgery. Okay, they are ablated and they advanced surgery.
What are the indications for surgery in abstinence?
Why you are going to final exam, you don't know what indication of abstinence surgery. Indication surgery in abstinence. Symptomatic. No, symptomatic. Dispute saturation less than 90%. Cardiomegaly, arrhythmia, and paradiscal hemorrhage. No, these are the conditions. Okay, so you only confined to two diagnoses, HDR and HDPH. Huh? HDR and probably there is endocarditis also. And what do you think, other guys? Anybody seen the case from history? What is your you tell what could the diagnosis from history?
What else?
Yeah. You have to give 3 to 4 diagnoses from history, provisional diagnosis. That means you examiner will know the natural history of the diseases. Okay. Volume of 100,000 conditions volume overload that. But you have to give diagnosis? No. He has got palpitation worsen. Now dyspnea 1 6 months ago fever. Three history, no? Three important points.
Yes,
Hmm? Huh?
sir, PSD here.
He told already. There wants.
RS.
What is the patient's age now?
40, sir.
Huh?
40,
40 BHDR right now.
40 years now.
40 years BHDR, why PHDR now? BHDR developed at the age of 40.
that-
Will
What is the
develop
cause of AR? BHD, okay, loan BHD can't explain? Only simple BHD can't explain your history. Why do you bring AR here?
was worsened in the 6
Huh?
worsening of the symptoms.
What?
From the past 6 months, the symptoms got worsened, sir. The development of a new
Worsen because of what?
of infective endocarditis.
So BHD with out of all endocarditis, we think of BHDR. This is the diagnosis.
What age AR starts in?
Early, the AR will start around 8 years.
2 to 8 years.
Then why 40 years you wait for the to AR develop now? It could be because of rupture sense of valve. Possible.
Do they present?
I think about RSO is possible.
Possible.
How do they present?
Will present with palpitations and dyspnea and exertion, and which was sudden in onset.
How many will have acute presentation? How many have gradual and how many will asymptomatic? Is 35% will have acute presentation. 50%. Not able to hear. Okay.
The dyspnea starts after the onset of a fever.
Yes, sir.
Huh?
Along with the fever.
Hmm. So think of BHD, existing BHD, that could be endocarditis. Out of all endocarditis, you thought of. So the AHD, I don't think you should bring AHD here from history. Hmm.
Volume overload.
She's asking, so when the patient have palpitation AHD, and what is the cause of palpitation in AHD?
Is volume over.
Huh?
One is volume overload, sir. Another one is of
Volume overload palpitation. Volume overload palpitation double AHD. Each patient, if they develop volume overload palpitation, what are the causes? Arrhythmia, no? All kind of supernatural arrhythmia possible in AHD. One. Two, if volume overload constant, there existing some other disease, matular disease. More volume, more of blood will go to right ventricle. That may produce
ASD.
palpitation. MR or MS with AHD. No. So you confine to the two diagnoses, BHD with out of all endocarditis here, and AHD we don't accept a diagnosis, and possible second diagnosis, third diagnosis could be rupture sensual salva. Go ahead.
The other thing is, you have, after history, you examine the patient also, you got the findings. So based on the findings, look at the history again, then give the interpretation of history. It's not that completely isolate your findings and think theoretically about the only history.
RSO will
Try
be
to
there.
keep that in mind and try to interpret the history.
General physical examination. So patient is conscious oriented, height. Patient is conscious oriented, height of 164 centimeters, weight 70 kgs with BMI of 26, overweight, arm span 162 centimeters, upper segment 83 and low segment 81 centimeters. And patient is febrile, pulse is 78 beats per minute, regular in rhythm, high volume, collapsing in nature, no radial delay, no radiofemoral delay, all peripheral pulses are felt. BP in the right upper limb 140/60, left upper limb 138/60, and left lower limb it is 180, and right lower limb it is 180, and left lower limb it is 178. And respiratory rate 18 cycles per minute, thoraco-abdominal type. All four limb saturations are 98, and there is no cyanosis, no clubbing, no pallor, no icterus or pedal edema. And JVP is visible 3 centimeters from above the sternal angle and 45 degrees position. Normal respiratory variation and hepatojugular reflex is normal. Blood pressure having a white pulse pressure and having a Hill sign positive. Hill sign is positive.
From BP recording, what is your impression?
He's having white pulse pressures.
Physiology.
Diastolic runoff conditions.
No,
high
what does
volume.
it indicate? What's happening especially in hemodynamics?
Diastolic runoff.
Normally, what is the blood pressure in the lower limbs?
It will be generally less than 20 difference from the upper limb.
But
Less
Why
than
is it higher? Why is the blood pressure higher in the lower limbs?
peripheral augmentation.
Why augmentation occurs?
Sir, lower limbs will have a more compliance and longer.
So there are a lot of reflex and reflected waves from branching points. Understand?
Explanation for Hill sign. Fact 35.
45. Because it is measuring the systolic.
Intraarterial water. Correlate to intraarterial recording. Intraarterial.
Measure the blood pressure in upper limb, lower limb. There'll be different.
So you told diastolic runoff to ventricle or what? And all blood going out, going back to ventricle. Diastolic runoff means what?
Going from high
Everybody
pressure
say diastolic runoff. I don't understand what diastolic runoff.
high pressure chamber to low pressure.
Huh?
High pressure chamber to low pressure chamber in the diastolic.
Anemia, what happens? Anemia. Anemia, you white pulse
Hyperdynamics.
pressure. Huh?
Hyperdynamics.
Hyperkinetic saturation. Hyperkinetic, why there white pulse pressure? Peripheral vasodilation does occur or not here? Peripheral vasodilation, peripheral vascular resistance decreases or not? These conditions.
Peripheral vasodilation.
Why? Why happens? Anybody can answer these questions here.
Why diastolic pressure is low in aortic to low systemic vascular resistance. That's what there is. Why there is low systemic vascular resistance?
Was all
Because of large
Large.
volume, there is reflex vasodilatation.
no peripheral signs of diastolic runoff, sir. No signs of
No peripheral, that's enough.
others. No other.
Horrible. Why you telling this? You told you told there is white pulse pressure and 140 upper limb, lower limb, 180 blood pressure, no peripheral signs of,
No other.
why do you mention these things? Why are you creating trouble for yourself?
Finance skull is normal. Previous gen.
No, clubbing कुछ नहीं है, clubbing.
No, sir. No, sir.
Sir,
No clubbing, no. Open.
how often you get clubbing in? Common or?
Will be there. Clubbing will come. Systemic examination, cardiovascular examination, inspection, palpation combined. Chest is symmetrical, precardial, there is no precardial bulge. Apex beat at chest is symmetrical. Chest is symmetrical. There is no precardial bulge. Apex beat is localized at 6th intercostal space, 1 centimeter later to mid-clavicular line with medial retraction. Is forceful, ill sustained. Probably is LV type of apex. Hyperdynamic. Parasternal heaving rate. Continuous thrill is palpable in the left parasternal region, 3rd, 4th intercostal space.
Continuous?
Continuous
Thrill.
thrill, palpable.
Continuous thrill. How do you know continuous thrill? Continuous thrill means what?
But throughout the systole and the diastole.
The thrill is present, fine. A long thrill there.
Yes. And suprasternal pulsations are there. There is no other visible pulsations. There are no other dilated veins or scars.
They are not able to hear you clearly, really. It is all because of the something.
Sir, suprasternal pulsations are present. Sir. No other pulsations.
Now
No
it's
other
better.
engorged veins or any scars. Percussion. Left heart border corresponds to the apex. Right heart border is retrosternal. Stomach tympani noted on the left side, and hepatic dullness noted on the right fifth intercostal space. In the 15th in the midclavicular line, and the left second intercostal space is dull.
Dull.
Does it mean?
Dilated pulmonary artery. To increased pulmonary blood flow.
Okay, before putting a stethoscope, can you just tell us what is the present situation? Before auscultation.
Auscultation, what is your interpretation?
The left side volume overload with continuous thrill.
Tell no, what could the
Possibility of Rsov.
doctors not possible.
Sorry, sir.
Doctors.
Doctors, PDA, can it be?
I'm able to feel thrill in the little lower,
Huh? What?
the
What?
3rd and 4th intercostal. And PDA at age of
Usually, where do you get PDA?
second.
Left infraclavicular, first and second intercostal space. Any other? Can it be just VSD?
You can get, you know, the person get thrill, long thrill. Confusing as very long thrill, you thought I could continuous. May not be, but very long thrill. Left on border. Upper stomach border.
For the window, continuous thrill. Venous hum.
Venous hum hard in pani.
One of
Sir.
your differential diagnosis was VSD-AR. Can that cause kind of?
PSD, AR.
Okay, you thought of rupture sense valsalva, I told. Rupture sense valsalva, no? You told ROCV. Then second time BHD air. And absent pulmonary valve possible.
And pulmonary valve, total and diastole both three.
Any other conditions?
ACR, biotic, biotic membrane with aortic regurgitation. And trauma. Actually, no.
This one normal, sir. S2 appears normal. I'm not able to appreciate S2 properly because of loud murmur. S3, S3 is hard
I
at
mean,
the
you're not able to make out S2 split.
S1. Murmur is and no other added sounds. Murmur
S3.
full sir. Apex.
Right.
LV or S?
LV, LV,
LV S3.
LV is murmur, continuous harsh mixed frequency murmur of grade 5/6, best heard in the left parasternal third and fourth intercostal space with no peaking at S2 and radiating all over the precardium. Then MDM of low frequency grade 2 by grade 2 heard at the apex with no presystolic accentuation, which is decrescendo in nature. No radiation, best heard in the left lateral position.
Mid diastolic murmur, where?
Apex grade 2. The system examinations was normal.
Diagnosis.
So diagnosis situs solutus levocardia. Yeah, structural like heart disease like Rsov to RVOT, left to right shunt, 2:1 shunt possible. Left to right, Rsov to
Left right shunt. And then
and 2:1. Greater than two.
exactly 2:1.
No, sir,
Huh?
greater than 2:2.
Huh?
Greater than 2.
Greater than 2:1. Then
Uh, Trying VST. EHA function class 3. Normal
No,
science.
this your anatomical diagnose finished. RSO to RVOT. RVOT told no, RA told. RVOT. Any other anatomical diagnosis? You have to bring your. You may suspect, no? It's a provisional diagnosis. If you could be able to.
Could be
Huh?
VSD.
PhD, okay. PhD.
VSD.
See, so listen, all of you, what Professor Tondon says. If you give a diagnosis of ROCV, always bring possibility of, because there is a murmur from beginning, from the childhood. And there is patient symptomatic from childhood, there is diagnosis to have some disease and advised surgery. So there could be BHD. And also you can't exclude air also. In the presence of BHD, always bring, there could be BHD and air. We can't, clinically we cannot say there can't be no BHD, no air. Even if also, supposedly BHD, you can miss an echo also. In the presence of ROCV. We want to diagnosis of ROCV, think of there could be BHD and air.
Often you get this.
What kind of BHD is common in ROCV? What kind of BHD? What type of BHD? Location wise?
Pulmon.
Subclinic PST. So 30% can get it, no?
Causes of continuous murmur you could think of.
S3, I say, think of the could be because congenital heart disease could be mitral valve congenital disease, could be some MS maybe there, MDM because of MS.
There is no prehistoric accident.
You may not get. It
And
depends.
This one is normal. Sir.
You can congenital heart disease S1 may be normal. Congenital metastasis. Why not congenital MS? Why do you think S3 here? Because of the what the cause of S3 here? What the cause of S3?
Increased shunting,
Uh,
overload,
MDM?
dilated. MDM is because of increased
Huh?
increased left to right shunt.
Why do you get MDM? I'm thinking of congenital MS, I'm thinking.
MS we can't get tested.
Can't think of it.
Why? MS there, no S3, S3 there, no MS. Why?
Diastole there should be a
Huh?
during the diastole the wall can't open completely. That is because of the increased rapid filling of
ST needs unobstructed AV.
The diagnosis or this is one diagnosis?
We have Rsov at that.
we newly developed RSO.
10 years back, he was advised.
You know,
It was advised surgery, is it? That
10
time.
years back.
he was advised for surgery that time.
Think the RSO is there from time or previous?
Yes, RSO we developed this on RSO we
What is the natural history of RSO?
years they will mostly like.
But the endocarditis also make.
We would go mention in history that history of fever 6 months ago and it remained for 1 month. So if you think that history, then any other things in diagnosis or 9 minutes left only.
This is for
9 minutes left. Okay.
include
Okay, ECG exercise. So ECG और एक्सरे देखा जल्दी देखा.
can endocarditis cause some RV fistula? Where endocarditis? Perivalvular complication.
Tell the complication of aortic valve endocarditis. Before you see that ECG, possible complication of aortic valve endocarditis.
Aortic regurgitation.
Hmm.
The perivalvular complication.
Abscess, periannular abscess. Then what else?
RSO.
अरे ECG नहीं आया?
What are the other complications of endocarditis?
Have a pulmonological and systemic embolism, peripheral embolism.
What else?
Immunological like glomerulonephritis. This is 12 lead ECG with normal sinus rhythm. With the normal
Read it fully and give the final impression about the ECG.
There is a epiatrial enlargement.
What would you axis tell? What is axis?
For axis no,
Normal, it doesn't mean what normal.
left axis.
Huh? Left axis.
Approximate axis you should.
Frontal plane axis कितना है?
You see lead 3 and tell us
Lead 3 is biphasic.
biphasic. So
Biphasic.
it should be right angles to that.
Nervous होने को कुछ कारण है?
Yeah,
Why? The axis goes parallel to AVR, no? So AVR is so called plus 30 or
six.
Plus 30. What about PR interval?
Prolonged.
not prolong? Why prolong? Prolong more than two. Line. Patient has got left atrial hypertrophy strain pattern, left atrial enlargement, and madam says PR is upper limb to normal. Biphasic P in also. So L enlargement there. No. So do you think it could be this is consistent with the RSOV? RSOV is acute or subacute condition, and patient will have a pitch of heart failure, no tachycardia, and a patient has ST depression, showing that is a long-standing pathology. And you think why not AS? What madam says, not ASAR.
Yes, yeah.
So naturally, VHT also, VHT can produce subaortic membrane, natural history VHT, subaortic membrane, RVT obstruction, subaortic, left side subaortic membrane. There is VHT, ASAR.
You stick with your continuous murmur or is systolic diastole?
Continuous.
So then how to explain then? It's a long-standing, this is a long-standing pathology. What do you say? No, sir. ST depression. ROC won't produce ST depressions. Patient go to heart failure and go for surgery. X-ray. So when you tell, this is my issue. Sir, my clinical diagnosis RSV, but patient has got no tachycardia, which is suggestive of a long-standing pathology. So there are things I am not able to explain. And in the context of ECG, I am thinking this and this. You should be proactive. You should you should keep on talking.
And in the history, do you have any history of what drugs, what he's taking?
He's on diuretic.
Only diuretic.
That too, he is not compliant. The chest X-ray, PA view, adequate exposure, no rotation,
No?
Rotation.
no rotation.
Hmm.
Showing there is a cardiomegaly with LV type of apex. There is a
Good right side heart,
light atrial enlargement. There is a
ascending outer,
pulmonary
ascending outer. Ascending outer,
Yeah.
normal, abnormal.
Can you trace ascending aorta?
ascending.
I don't see, no?
Ascending,
That's it, ascending outer dilated, no?
not dilated.
There is left atrial enlargement. ECG we saw left atrial.
Yes.
X-ray wise.
What are the findings you look for?
In X-ray, shadow in shadow. Playing of the carina. Playing of the.
Third, left atrial appendage, is it prominent? Where do you look for left atrial appendage? What vascularity, pulmonary vascular.
There is a.
There is systolic murmur, listen, giving a systolic murmur. X-ray is the left lateral appendage there. L enlargement, L appendage present there. What is your diagnosis? Systolic murmur, non-systolic murmur or whatever may be. Systolic murmur there. X-ray is L enlargement, it left lateral appendage present. Enlargement. What is the diagnosis? First diagnosis. You should not take half an hour to think. You should not take half an hour to think this answer.
You say pansystolic murmur. So
MR,
MR. Why not a BHD?
PhD is left atrial. Left atrial.
Huh?
Left atrial and
When appendage enlargement, think aromatic. Okay. Okay, so what else there? There is cardiomegaly, RLM there, ascending outer dilated, and PA segment what happened? PA segment is full or it is, you think the PA enlargement there?
MPA is dilated.
Yeah.
PA is prominent.
Okay, then what about to right PA, RPA and LPA? LPA not able to see, RPA. Pulmonary vascularity, I mean to say pulmonary vascularity, because your diagnosis is left right shunt more than 2:1.
Yes, sir.
So
The venous is a capitalizations with
venous capillary not because of left right shunt. Venous capillation because what? Venous, because of what?
of left.
Huh?
Side. Venous hypertension is because of left side heart. Left side.
Left side. Pulmonary
Venous hypertension is because of back pressure.
Back pressure.
pressure.
What is back pressure and front pressure talking about? What is back pressure? Back pressure, front pressure. What is back pressure, front pressure? What is that?
Left,
Huh?
left side, the failure.
These left
Left side, left atrial pressure.
So tell me what is the X-ray finding of increased pulmonary vascularity?
There is a
MPG, okay, MPG enlarged told. Then what about the central arteries? RPA, LPA, and
LPA is related. LPA is
end-on vessels. Arterial bronchial ratio. You have to talk like this. How much coming 1/3 or coming to lateral third of the long field. So these are things to no, there are signs of increased pulmonary vascularity. You should narrate those things. Okay, echo. So what do you think of ECG X-ray? What do you think? What is ECG X-ray before going echo?
so there is a cardiomegaly with
No, what is your diagnosis from ECG
So
X-ray
they support your diagnosis both ECG together.
and clinical findings?
it will support, but right atrial enlargement was I told Rsov to RVOT. Atrial enlargement I have.
You can't explain. RFS only increase, RSOV to RVOT, RFS only increase.
It will increase.
Huh?
It will increase.
JB raise or not here?
Normal.
JB raise or not?
No.
Not raise.
Not.
Have you done that all the hepatojugular reflux done?
Yes.
Abdominal jugular reflux done?
Done.
Not there. Oh, that is patient on treatment. No? Patient treatment. Okay, so RVOT you think of, and possibly there could be pre-existing VH and AR.
Any minutes?
Is a parasternal long axis view showing the LV enlargement.
Take the mitral
Mitral valve, posterior mitral valve look thickened, restricted.
valve.
LA, LV, all RV.
This is the color Doppler. The trivial AR is a shunt from this RCC to RA. Sorry, RV.
Better to
No,
comment.
then no
It's not.
no overrides completely. Because of cusp. It's not completely override, so partial. Less than 50%.
Nothing complete override. Do you think a complete override there is any other describe complete override? PhD severe AR, okay, MR also there, LA enlargement there. There is incomplete opening metal valve because in case LVDP. So what bicuspid, tricuspid, what is this valve?
Is a aortic short axis.
P.
Is tricuspid aortic.
There is a vegetation there.
The pulmonary wall, there is some thickening over here.
Time. Oh, this arrow in the mouth of arrow is ROC. What is that? Some vegetation is coming down or what?
Sir, this one, RCC. Just all like a vegetation, thickening up. Yes. This is a RSOV, RCC to RVOT.
Right sinus, not right cervical. It be VSV. It be VSV.
And it is continuous.
PhD here. Supposedly PhD can't exclude. In presence of ROC, RBOT can't exclude. Even echocardiographically can't exclude. But can overlap. Very difficult. Summarize your spinal diagnosis.
Sir, situs alters livocardia, cyanotic RSOV to REOT with possible of restrictive of EST to right shunt from
RB, then what else then?
right to left shunt.
See, here you
Sir,
fever here. See, total nervous. Good student.
right shunt.
From echocardiogram, no, it is from echo, how much shunt magnitude? Here. Shunt magnitude, can you tell from echo? You can't say. If we give in to this case to you to do echo, can you calculate magnitude of shunt? Yes or no?
Yes, sir.
How?
Sir, PTA,
The sir is just asking you why did it, because you have done it before, you told it before, how do you calculate a QB based on echo? That's what he's asking. The presence of shunt is the absence of shunt. How do you calculate?
continuity. PTA
What
and
continuity?
PTA and cross section.
You can QPQS, you can calculate QPQS. Okay.
No, I think you have made a good effort in presentation. I think you accepted to present the first case. So compliments on that, but I think you'll have to improve your presentation, speak loudly, and be more clear about some of the basics.
Defensive, very defensive way. The first case, your opener, so little nervous. Fine. Thank you, sir. Thank you, everybody.
I thank all the three moderators for this wonderful talk and this exposition of the case. Sir, just to give a briefer, yes, sir. Just to give a briefer, this patient underwent This patient underwent a cath in 2010 in Puttaparthi, which showed subpulmonic